The health of IVF babies. What do we know? What do we need to find out? This event has been made possible thanks to the generous support of the Scottish Government, and we at PET are extremely grateful to them. In the run-up to the birth of the world's first IVF baby, Louise Brown, back in 1978, there was a great deal of speculation in the media about whether she would be normal. And as Louise herself has said, had there been anything at all wrong with me, it would have been the end of IVF. And I think she's right. But now clearly she was fine. And there have been more than 8 million babies born worldwide as a result of IVF. And Louise and other IVF children have gone on to conceive naturally and have children themselves. Tonight, we're hoping to unpick what we know about whether the way IVF children are conceived has or may in future have any impact on their health. And the discussion will include what we know, and just as importantly, we'll be discussing what we need to know. Because if we don't look for things, we won't find them. That's something I'm always telling my husband. But seriously, we know about the complications and the health implications caused by multiple births, and great work has been done to drive the number of multiple pregnancies down. But what is known about whether a particular step in the process of IVF has an implication for the children's future health? To be clear from the outset, we're not trying to scaremonger here. And we all need to keep in mind that the vast majority of those 8 million plus children are all okay. So tonight we're going to hear from 4 experts who've carried out research in this area. Professor Daniel Brison, Professor Anja Bisgaard Pinborg, Dr. Carrie Williams, and Dr. Sebastiaan Mastenbroek. Daniel is Professor of Clinical Embryology and Stem Cell Biology at the University of Manchester's Maternal and Fetal Health Research Centre. He's authored UK-wide cohort and cross-sectional studies of the health of children conceived via IVF.
So I'm delighted to be here to speak on this very important topic and honoured to be asked. Thank you. So as Sarah said, I'm based in Manchester in the UK, and I just have one disclosure slide for you all. So I'm employed by the National Health Service in the UK as a clinical embryologist, and I do hold research grant funding, which is relevant to this talk. It's funded a lot of the work. And I'm going to mention this several times. The majority of our funding on this work has been from the European Commission. But very important for this talk, I don't have any personal financial interests in the work, so no payments to me personally. Okay, so moving on. We all know about human-assisted reproduction technology, ART. We know that 1 in 6 couples worldwide suffer infertility. We know how important these treatments are. And as Sarah said, since 1978, when 8 million IVF babies have been born, and I'm very proud to remind everybody that this work was pioneered in Greater Manchester, of course, by Steptoe and Edwards. And as Sarah's already told us, the major take-home message so far is that there are no major health issues with these babies. The vast majority of them are healthy and well. However, ART does influence the births of between 2 and 3% of all children in the UK, and even a higher proportion in Europe. And therefore, the lab and clinical practices we carry out in IVF clinics have the potential to affect tens of thousands and more babies annually. So I'm going to talk briefly about birth weight and child growth in our UK ART cohorts. So what do we know already from other studies? Well, these studies have been going on for 10 or 20 years or more, and many of them are based in Europe and other countries around the world that have done this in advance of the UK. So we know that IVF babies have altered fetal growth and birth weight. We've known that for many years. And we also know that this is important because early life events can impact long-term health. And this has come through our understanding of the developmental origins of health and disease. So this slide is very important. David Barker pioneered the DOHAD field probably more than 20 years ago now. And he told us that we now know that poor fetal growth and small size at birth are followed by increased risks of all these diseases, which are collectively known as cardiometabolic diseases, so type 2 diabetes and coronary heart disease. Further to that, we know that epigenetic mechanisms may be involved. by which environmental influences can be transmitted through the embryo. We know that we can measure birth weight as a valuable proxy for fetal growth, but we also know that early child growth is important, that is, catch up from small size at birth and catch down. And there's been a very interesting debate in the pages of human reproduction just this last week, following a paper published from a group in Norway, Magnus et al., and a response from Tessa Roseboom this week, which I hope we'll have time to discuss later on. Okay, so further to that, what else do we know? Well, we know that IVF babies are low birth weight only from fresh transfer. So we don't know whether this is caused by the embryo culture environment, for example, the culture medium, which Sebastiaan Mastenbroek will talk about later on, or perhaps other clinical practices. And we also know that IVF babies from frozen transfer are normal birth weight, even slightly larger than naturally conceived. But again, we don't know whether this is a response of the embryonic freezing or possibly to do with the uterine environment. So if we go back a number of years ago to the work that my group has done, we designed a number of studies based on the resource we have in the UK. And our major resource is shown here, the Human Fertilization and Embryology Authority, the register of all ART births from 1991 onwards. And if you look at this large box, we've followed the trajectory of some of these children from 1991 to 2015, that birth year, across a number of clinics in the UK, which totaled 82 at the time we started the studies. And we looked first at the HFA's register. And we weren't the first to do this. The first linkage study from the register was carried out by Alistair Sutcliffe's group, and Carrie Williams pioneered this work, and she's going to talk about that in a moment. And we followed on with our study 2 or 3 years later on child growth. And what we found was that if you took the HFA register with all its many births, cycles and births, and link it to particular databases, in our case, it was a Scottish database, which is a happy coincidence for this talk, we were able to track the births of 5,000 singleton IVF babies and compare them to 20,000 naturally conceived controls. And what we found very briefly from that study, which I won't go into in detail, it's been published now, we saw on this graph here that babies born from fresh transfer were lower birth weight than naturally conceived, shown in black. We already knew that. But what this study added was that these babies continue to lose weight by 6 to 8 weeks, where they now weigh considerably less than naturally conceived children. And yet by the age of school entry, they've caught up. So they're exactly the same weight and size as naturally conceived children. And in contrast, children born from frozen transfer weigh slightly more at birth and then have a relatively normal growth trajectory based on these time points compared to naturally conceived. So this tells you 2 things. It tells you that fresh IVF babies are born low birth weight, which we already knew, but it also tells us that they experience catch-up growth, which we hadn't really observed previously. And that's not a good thing, unfortunately. That's a second risk factor for cardiometabolic disease in later life. And that was the subject of Tessa Roseboom's letter to Human Reproduction this week. Okay, so having established that, we go back now to the HFA register, and we designed 3 interlocking studies, and they were carried out by a PhD student of mine, Catherine Castillo, funded by this European network, EpiHealthNet, and she published these in the last 2 or 3 years. The first study, we looked at a longitudinal set of children born over 25 years at St. Mary's Hospital, and we found that a couple of interesting things. One of them was that the birth weight of these children had increased fairly steadily over the last 25 years. So the babies born in 2015 weighed nearly 300 grams more than those born in 1991. And that applied equally to both fresh babies and frozen transfer babies. And by the way, over this time period, the naturally conceived population had not increased in birth weight at all. Unfortunately, we were not able to map any of these changes onto particular ART lab factors. And you can see on the right here, the kinds of things we tried to analyze by a logistic regression analysis, but it was quite difficult to do that in this type of study. And in fact, that's really one of the main take-home messages of Catherine's PhD, is that we can do very large retrospective studies, very well designed and very well analyzed, but it's very difficult to pick out factors that are involved in the process, and I'll explain why. So in these studies, we looked at the hypothesis here was, can we pick out factors in the IVF process which are explaining success rate, for example, IVF for ICSI, the type of culture medium we use, number of oocytes or embryos we transfer, and do those also affect the incidence of preterm birth, gestation, and birth weight? And largely speaking, the answer is no, they don't. Only a couple of factors such as blast transfer or the number of embryos replaced, affected both success rate and birth weight, or incidence of preterm birth. But generally speaking, there wasn't that big an overlap, and we found relatively few factors that independently associated with birth weight. And the reason for this is interesting. This is because we found that the clinic itself was the major factor. So these analyses were dominated by the clinic site itself. And of course, we don't know why. So just to summarize those 3 studies, really, they're all published now in Human Reproduction, but we found that the culture medium type has a minor association with success rate. We found that blast transfer itself was associated with preterm birth, but we were not, even with these carefully designed studies, able to identify any specific lab factors or patient stimulation factors that were associated with birth weight changes, largely because the dominant trends were time, over 25 years, as I've said, and the particular clinic site. Okay, so just to reiterate that in the last couple of slides, our studies have contributed to the field, I think, by showing that catch-up growth occurs in low birth weight babies to school entry age. And as I said, Magnus et al. In Norway have shown that in a different sample this last week. Both of these, low birth weight and catch-up growth, are independent risk factors for cardiometabolic disease. Frozen transfer babies show a growth trajectory closer to naturally conceived. And finally, these large retrospective studies are not able to identify lab factors, but have identified clinic site as important. So that leads me on to my last slide, of course, which is really the very important topic of what do we need to find out now? So what do these studies lead us on to? And there's some very clear questions here. So why do low birth weight and catch-up growth occur in ART children? It could, of course, be parental and subfertility factors, and I think Professor Pinborg is going to address that. We don't know whether the stimulation regimes we use in IVF are partly responsible. We don't know whether embryonic environmental factors such as culture medium composition, oxygen tension, other aspects of the culture system may be responsible. And of course, these unknown factors in the clinic, they really fascinate me because we have no idea what they may be. We simply know that they're important. We also need basic scientific studies of mechanism. For example, we need to understand how the embryo passes on epigenetic changes into the offspring, responding to environment. And also a major focus of work in Manchester is looking at the interaction between the embryo and the endometrium to see whether one of the axes of control takes place there. We also need long-term studies of cardiometabolic health in these children because the IVF children now are reaching age 40 plus when they might be expected to develop some of these clinical diseases. We also, I think, very importantly, need to improve the way we collect information at a national level. So the HFEA register is very good, but it doesn't contain a huge amount of detail on lab factors. For example, it doesn't contain culture medium type. We also need to think about how we extend these studies in the future. Carrie will tell you that we studied the cohort up until 2010 extensively, but we haven't yet looked at the cohort after 2010, and there are particular reasons for that. And finally, the one really strong take-home message I'd like to leave you with at the end of my talk is that we need a multidisciplinary approach to this subject. We need embryologists and basic scientists. We need a variety of medical people, ART and OBGYN people, but we also need pediatricians and child growth experts. And I've seen a number of papers in this field that don't have input from all those areas. And I think that's really important, as well as statisticians, of course. Okay, I'm just going to leave you finally with just a short reference list, which I'm sure you'll be able to access after the talk is over. So they're there available if you like them. And perhaps I'll just I'll finish now. Thank you.
Our next speaker this evening is Anja Pinborg, who's Professor Pinborg, and she is the chief consultant at the Rigs Hospitalet Juliane Marie Center in Copenhagen. And Anja has authored research into and commentary on the health of IVF children.
Thank you to the Progress Health Educational Trust for inviting me to participate in this very interesting debate with the highly experienced expert. And thank you to Sarah also. My topic will be the health of children conceived by ART, the chicken or the egg. And here are shortly my conflicts of interest. As Daniel already said, more than 8 million babies have been born worldwide after ART, and the ART birth cohort comprises up to 8% of the European birth cohort, with Spain lingering as the highest country. This is data from the IEM consortium being reported from ESRA every year. So I will base my talk on a recent publication in Human Reproduction Update, a grand theme review with the health of children, the chicken or the egg. And what we tried in this paper was to of course, report on adverse outcome in ART children, luckily not so many adverse outcomes, but also separating the contribution of the infertility per se from the ART techniques. And no doubt when we treat women and men with reproductive diseases, they also have a higher risk, in particular of perinatal adverse outcomes and obstetric adverse outcomes. Let us take a look at this picture. Daniel has already mentioned many of these factors, but if we look to the upper part, when we have a baby, it can be influenced, or the health, both short and long-term health, can be influenced by parental factors like genetics, reproductive disease, environment, and the parental age, both the mother's and the father's age. And we know that all these factors influence short and long-term morbidity. We also have the influences by the ART techniques, the ICSI stimulation, ovarian stimulation regimens, number of embryo transferred, of course, cryopreservation, egg donation, and then we have the in vitro culture, also mentioned by Daniel, with the culture media, the culture time, and also the manipulation by assisted hatching and trophectoderm biopsy. A very important factor, and I don't think you can mention health in ART children without also mentioning that we have actually been able to improve the health of the children by lowering the number of multiples born after ART. And here you see a publication from the Committee of Nordic Art and Safety, including more than 170,000 ART children born in the Nordic countries. And upper to the left, you see that here's the multiple births, and you see that that Sweden, which is the yellow line here, has been able to lower the multiple births mostly. Actually now in 2021, the multiple birth rates are like they are also in the Netherlands and Belgium, and also in the UK, have been lingering down to less than 5% in all of the Nordic countries. And this has resulted in this figure to the right, where you see the blue line, which is Sweden, and you see clearly the preterm birth rate in Sweden has concomitantly with the lowering of the multiple birth rate also lowered the preterm birth rate. And I think this is one of the most important health factors for children born after ART. Another important issue is that the number of ICSI children have been steadily increasing and is now lingering. Procedures are now lingering. About 50% of our procedures are done after ICSI. In many countries, however, this number is up to 100% ICSI procedures, which may not be right when you think of the invasive procedure that ICSI is. And also the children born after cryopreservation techniques are steadily increasing. All things that actually can influence the short and long-term morbidity of the children. One of the first slides in the health of children conceived by ART is the preterm birth, and here we see that the risk of preterm birth in ART singletons compared to the background population is around 2 in all the large systematic reviews and cohort studies. Further on, when we look at very preterm birth below 32 weeks, the same is seen, even a higher risk of very preterm birth of up to 3.5-fold increased risk of preterm birth. And for perinatal mortality, again, a 1.5 to 2.5-fold increased risk of perinatal mortality, even in singletons. And how come? We try to disentangle this by looking at different cohorts of children. And we looked at a cohort of children born after subfertile mothers, mothers who conceived spontaneously, but had more than, whom it took more than 1 year to conceive versus natural conception. And in the first line, you see here from the systematic review published in 2013, in a subfertile population compared to a fertile population, where both populations conceived naturally, there was a 35% increased risk of preterm birth of the subfertile mothers. When we compare IVF to the subfertile population, this risk difference was even more pronounced, with a 55% increased risk in the IVF population compared to the subfertile. Ovarian stimulation also per se, without any invasive procedures, also increased the risk of preterm birth. ICSI versus IVF, we found no increased risk, indicating that ICSI mothers are the healthy, where the males have the problem here. Cryopreservation, as we have seen in many studies now, lowers the risk of preterm birth compared to fresh embryo transfers. And sibling analysis, in those studies where we compare a mother who has both given birth to an IVF child and a child after natural conception, we see a 27% increased risk of preterm birth in the sibling analysis of the IVF child. So I think we can conclude from this slide that both the procedures per se, but also the health of the characteristics of the infertile couples, both the mothers and the fathers, actually influences the child health. And again, here we see differences between different procedures, again indicating that fresh embryo transfer is not the same as frozen embryo transfer when it comes to the influence on the child health. To the left, you see preterm birth, low birth weight, small for gestational age, being large for gestational age, having a birth weight of more than 4.5 kilo, and postterm birth. And you see the red columns, which represent frozen embryo, children born after frozen embryo transfer, that they have a lower risk of preterm birth, low birth weight, and small for gestational age, but on the other hand, a higher risk of being large for gestational age and weighing more than 4.5 kilos and having a postterm birth. So something is happening in the early pregnancy, which indicates also when the child is born and how much growth it will take on during the pregnancy. Again, we have looked at siblings, where we have looked, here you see the curve for a mother giving birth first to a spontaneously conceived child and then another spontaneously conceived child. And as we know, the second child has on average a higher birth weight than the first child. But when it comes to frozen embryo transfer, we see that if it's a mother who gave birth first to a child from fresh embryo transfer, here the dark green line, and then a frozen embryo transfer, you see that the risk difference between, or the difference between the mean birth weight in the first and the second child is much steeper than when we look at the blue line, which was representing mothers who gave birth first to a spontaneous and then another spontaneous child. So there is some kind of overgrowth in the frozen embryo transfer children. And the same is seen, the opposite is seen if we have a mother who first gave birth to a child from frozen and then from fresh embryo transfer. Then we don't see the expected line that goes up, but rather a declining birth weight in the second child born after fresh embryo transfer, indicating again that we cannot say, as I thought in the beginning, that the methods has nothing to do with it. It's only represented by maternal or paternal factors. Now, finally, to the long-term health of ART children, which I think is also important for the rest of their life, of course. I will just briefly introduce you to some reports on neuropsychiatric morbidity and then on cardiovascular morbidity, also touched upon in the previous talk by Professor Brison. Here we have the academic performance as a proxy of intelligence in the ART singletons, and we have looked at that in some Scandinavian cohorts published in Human Reproduction in 2017, where we looked at ART singleton versus non-ART singleton background population. And in the crude analysis, we found that the crude score at the 9th grade in the school, which represent children ending the normal ground school at 15 years of age before entering high school, they had a crude higher performance score than the background population. And here it's important to mention that all children in Denmark go through the same exam at the 9th grade in school. So all children, both public and private school, enter the same exam. And the mean difference when they were adjusted for maternal education actually showed a slightly lower result in the ART singletons, but very low, only 0.02 in the confidence interval, so probably not clinically relevant. We found similar school performance in children born after frozen and fresh embryo transfer, and in the Swedish studies, they have looked at ICSI versus IVF children and found similar school performance. So this is really reassuring data showing that IVF children actually in different also technologies are doing as well as a background population. Now, another question that I always get when I give talks about children born after IVF, it's the autism spectrum disorders, which indeed has been increasing in also the background population during recent years. And that's really important to take into account that the background population of autism spectrum disorders has also increased. And here's a huge study from the US Massachusetts cohort where they looked at more than 10,000 ART children and 8,000 children born of subfertile couples conceiving spontaneously, and then a fertile birth cohort of 440,000 children. And when they compared all these cohort, ART versus fertile, subfertile versus fertile, IVF versus fertile, and ICSI versus fertile, they found that there was no increased risk of autism spectrum disorders in any of these cohorts of ICSI and IVF children, neither compared to the subfertile nor the fertile population. And two other recent reports, or one recent report and another Swedish study published in 2013 showed the same. They actually also showed that there was a slight difference when they adjusted for multiplicity or multiple births. This risk difference disappeared between IVF and the background population. So reassuringly, I think there's no studies. There are some smaller studies indicating high risk of autism spectrum disorders, but they have also a high risk of bias inherent in the studies. And then here, a BMJ study published some years ago now from another Danish group who looked at any psychiatric diagnosis in the IVF and ovarian and IUI populations. And what they found was that there was no increased risk of any psychiatric disorders in either IVF or ICSI children, but rather in the OI, ovarian ovulation induction cohort and IUI cohort, they actually found a slightly higher risk of psychiatric disorders of 1.20, but this was only seen in psychological development and behavioral and emotional disorders. And this is probably due to the fact that many of the women, or an overrepresentation of women with anovulatory disease or endocrine disorders here, might also cause changes in the, who has developed from changes in the brain also can cause these increased risk in the children. We don't have any indications that IUI per se should cause high risk of psychiatric disorders. So this is probably due to maternal or paternal factors here.
I'm going to have to hurry you. I'm sorry.
Yeah, I have only 2 slides left, sorry. For cardiovascular health, we saw no increased risk in this publication from Halliday in cardiometabolic risk in very few children, but nevertheless, one of the biggest studies. But two studies from Switzerland has shown a slight increased risk of cardiovascular health risk in ART children. So I would end up by concluding they also showed higher blood pressure in the IVF children. So to sum up, there's similar school performance in ART and non-ART children, and neurodevelopmental diseases including autism, type 2 diabetes in offspring should not to be associated with ART, but there may be a cardiovascular health which is compromised. And I think this needs to be examined both in large cohort studies with long-term follow-up, as Professor Brison mentioned, but also in studies where we have the children in for physical examinations.
Our next speaker is Dr. Carrie Williams, and Carrie is a clinical paediatrician and a National Institute of Health Research Fellow at University College London's Great Ormond Street Institute of Child Health. She has authored research into cancer risk among children conceived via IVF, which we've already heard mentioned by Professor Brison earlier. So I'm going to hand over to you now, Carrie.
As Sarah said, I'm Carrie Williams, and I've been asked to talk to you today about cancer risk in children born after IVF. So I don't have any conflicts of interest, but I wanted to say that I'm an author of one of the studies that I'm going to talk about, looking at cancer risk in children born after IVF. And in the spirit of what Professor Brison was talking about, multidisciplinary teams, I'm a clinical paediatrician, which is a little bit different to a lot of the researchers in this area, or some of the researchers in this area. So first of all, why would we want to investigate cancer risk in children born after IVF? Well, as it has been pointed out a few times so far this evening, there are at least 8 million children born by IVF worldwide, and this number is rising. And although childhood cancer is thankfully a relatively rare condition, and 80% of children who have childhood cancer survive for at least 10 years, it's still a really serious condition. And understandably, there's a lot of parental and professional concern surrounding this. There are also theoretical reasons why children born after IVF might be at increased risk of cancer compared to those born by spontaneous conception. And this, as Daniel alluded to before, is largely, the theory is largely related to epigenetics. And epigenetics is a term that we use to describe various different mechanisms that control how and when our genes work. Now, as I'm sure will be discussed in the next talk, IVF involves exposure of the embryos to various different things like culture media and physical stress at the same time that a very important epigenetic reprogramming is happening. And as a result of these exposures at this really critical time, it's possible that changes in fetal epigenetics might occur. And indeed, when researchers have looked at this, they have found some altered epigenetic patterns in IVF human embryos, in IVF cord blood, and in IVF placenta. Now, separately from this, epigenetics has also been associated with the development of various types of cancer, including various types of childhood cancer. Now, this is by no means proof of a link between IVF and cancer. However, it is a possible mechanism whereby children born after IVF might have a higher increased risk of cancer compared to those born after spontaneous conception. And indeed, lots of authors have looked at this question over the years. Early studies tended to be case reports. And while these, so case reports of IVF children who've sadly developed cancer. And while these cases are dreadful, they give a biased picture, as they don't include children born after IVF who don't develop cancer, or children born after spontaneous conception who do develop cancer. Even when the early studies were well designed, they tended to be rather small. And because cancer in childhood is a rare outcome, thankfully, big studies are needed to ensure that we include enough cases to be certain of results. And therefore, even when the early studies are very well designed, results between studies tended to vary a lot. So this here is a quick systematic review that I did about 10 years ago. And the bigger studies are towards the top. And this is decreased risk of cancer in children born after IVF compared to comparison groups. And this is increased risk of cancer in children born after IVF compared to comparison groups. And as you can see, in the early studies, the results tend to vary quite widely, and this is probably because they had small numbers in them. Over the last decade, there have been more larger studies that are population-based, looking at cancer risk in children born after IVF. And indeed, I was involved in one of these studies in the UK with a group from UCL, from Oxford University, and from Edinburgh University. And what we did was we used HFEA records of 106,000 children born after IVF. As Daniel's talked about the cohort previously, we used that cohort and we anonymously linked them to the National Registry of Childhood Tumours. And we included children born between 1992 and 2008, and we achieved an average follow-up of 6.6 years. And what we did is, after this linkage, we were able to determine the number of this cohort who went on to develop cancer. We then compared the number of cancers we found to the number that we might expect if this cohort had the same cancer risk as the general population of the same age over the same time period. And we found 108 cases of cancer in this cohort, compared to 109 cases expected. And for those of you who like numbers, this gave us a standardized incidence ratio of 0.98, which is really close to 1, which means no difference between the two cohorts, the two populations. When we looked by sex, age, birth weight, number of babies per birth, by IVF type, and by infertility cause, we found no difference in the number of cases we found to the number of cases we expected to find. We then went on to look at different types of childhood cancers. And for most of the childhood cancers, we found, again, no difference in the number of cases that we found compared to the number of cases we were expecting to find. However, we did find 6 cases of liver tumours compared to 1.65 expected. And when we looked a little bit more closely at this, they were all a rare type of liver tumour, an embryonal liver tumour called a hepatoblastoma. And in our particular cohort, almost all of those children were born either low birth weight or very low birth weight. And low birth weight is known to be a risk factor for this type of tumour. We also found a small increased risk of muscle tumour within our cohort. But again, the number of cases we found was quite small for both of these increased risks, and therefore the absolute risks in these subgroups were really quite small. At the same time we were doing this, Professor Pinborg, who you've just heard from, was part of a study carried out in the Nordic countries, looking at 92,000 children born after IVF. And they did a similar thing to us in that they linked records of these children to national registries to determine the number who developed cancer. Now, they also had a matched control group, and they had 4 controls for every one IVF child. And they were able to adjust the analysis for country of birth, maternal age, sex, and gestational age. And they had an average follow-up of 9.5 years. They had relatively similar results to what we found. So they found no overall cancer risk in their study. So they had an average of 2 cases of childhood cancer per 1,000 children in the IVF group, compared to 1.8 cases of cancer per 1,000 children in the control group. And when they looked by different types of cancer, again, they found no difference in the cancer risk between most of the, when you look at most different types of childhood cancer. And they did find a small increased risk of CNS tumours and a small increased risk of epithelial tumours, mainly malignant melanomas. But as our study had found, the number of cases that they observed was quite small, so the absolute risk of cancer in these subgroups was also quite small. More recently, the largest study published so far in this area was by an American group headed by Barbara Luke, and they followed 275,000 children born after IVF in 14 different states between 2004 and 2013. And they did, again, a similar thing, linking these records to registries to determine the number of children who developed cancer. And again, they had a control group, and they had 10 controls for each IVF child, and they were able to have 4.5 years follow-up on average. They also adjusted for sex, number of babies per birth, state the baby was born in, maternal education, ethnicity, and age. Now, like our study, they didn't adjust for gestational age or birth weight, and this is like our study, but different to the Nordic study. And similarly, they found no overall risk of cancer in this study. However, they had a slight tendency towards increased risk, but this was found not to be significant. When they looked by different types of IVF, they found no difference in cancer risk between the IVF group and the control group. And when they looked by different cause of infertility, again, they found no difference between the two groups. They also did what we did in the other two, what was done in the other two studies was look at different types of childhood cancer and look at the risks for each different type of childhood cancer. And for the vast majority of those types, they found no difference between the two groups. Now, interestingly, similar to our study, they did find an increased risk of liver tumours, and theirs was also predominantly this rare form of embryonal tumour, hepatoblastoma. And that seemed to be what was driving the majority of this tendency towards an increased risk. Now, in their data, I couldn't find any actual association. I couldn't find any data about the association between low birth weight and this type of tumour in their population, but we do know that they didn't adjust for birth weight and gestation. So again, the number of cancers they found was small, and therefore the absolute risk was small. So I just wanted to mention just two more studies that were undertaken. One was a Danish study published a couple of years ago that looked at 37,000 children born after IVF. And they found a small increased risk of cancer in children born after frozen embryo transfer. However, a note of caution with this result, their group of children born after frozen embryo transfer included 3,500 children compared to, say, our study had 12,500 children. So because this is quite a small group, it perhaps introduces some element of uncertainty to this result. And again, the small numbers of cases they found meant there were small absolute risks. Another recent study was from a group from the Netherlands who looked at 25,000 children born after IVF, and they also included a group born to women who had subfertility but didn't have IVF, as Anja was talking about, sort of looking at the subfertility aspect of it too. And they found no difference in cancer risk between the different groups. And they also managed to follow up their cohort for 21 years. So in summary, most of the studies that have been carried out so far showed no overall cancer risk. And this should provide at least some reassurance to children born after IVF, their families, and people who are thinking about undergoing IVF. There have been possible increased risks identified in various different subgroups, but on the whole, this has been pretty inconsistent between the different studies, which raises the possibility that some of these findings may be chance findings. The only risk in a subgroup that has been consistent between at least two studies was the risk of hepatoblastoma. And I can't really comment about the American study, but certainly in our study, it appeared to be mediated by low birth weight. So as Daniel was talking about, children born after IVF are more likely to be low birth weight. And children who are born low birth weight are more likely to develop hepatoblastoma. And that's true even in non-IVF populations. As I'd like to stress again, absolute risks are small, and therefore the risk of an individual child developing this type of rare tumour or any of the other tumours that I've talked about is relatively low, or is very low. However, most of the studies, the follow-ups have been relatively short, and therefore longer follow-up studies are really needed to ensure the health of this population as they enter adolescence and adulthood, for more information to ensure their long-term health.
Finally, now this evening, we have Dr. Sebastiaan Mastenbroek. Sebastiaan is a senior clinical embryologist at Amsterdam's UMC's Centre for Reproductive Medicine, and he too has authored research into and has written commentary on the health of IVF children.
Thanks a lot for the invitation to be here. It's a pleasure, and I'm really enjoying myself this evening with the lectures that we've seen so far. Here's my conflict of interest slide. I do a lot of things, but I don't have any financial personal conflict of interest to report tonight. And what we've seen in the past talks, that there are some parts of the ART treatment that will affect the health of the children born. And perhaps also the risk profiles later in life. But what parts of the IVF treatments are involved, that's something that we still don't know exactly. It could be the ovarian stimulation, could be the freezing, the thawing, but tonight I would like to focus on the embryo culture, and specifically the embryo culture media that are being used for culturing embryos. Why? Because I'm a clinical embryologist and I think it's an interesting topic, but it also can learn us a little bit on the difficulties of doing these studies, and it also explains a little bit on why we still have so many questions on this topic. But first of all, is it logical to assume that 3 days or 5 days of embryo culture in the lab can have an effect on the health of children later in life? And yes, there is some biological rationale to it, but also some clinical evidence, and I will go through that. And the biological rationale was already mentioned by the previous speaker, and it is that so many interesting things happen during these very early days after fertilization, the pre-implantation stages of embryo development. There is a lot of biological processes going on that happen at that time, and it will never happen later in life. And there are many processes, but one has already been mentioned this evening, and that is, for example, the complete reprogramming of the epigenetics at that stage. And you can imagine this like a lot of switches on a DNA that are being taken away and reprogrammed, and those switches are more or less set for the rest of your life. So you can expect this to affect further development as well. So there is some biological rationale, but also some preclinical data on animals where you can experiment in ways that you of course cannot do with humans. And what you see here is, for example, a study where they fed the mothers with a low protein diet, especially during the pre-implantation period of development. And if you do that only during these stages, you see later an effect in the offspring on the birth weight, on the growth rate, hypertension, but also, for example, on the risk of anxiety-related behavior. But this is, of course, by feeding the mothers. So can we pinpoint it any further to the pre-implantation culture, or, for example, culture media? And yes, we can, because there is also experiments being performed in mice and in rats, where they changed the culture medium and, for example, had a medium where the insulin and branched chain amino acids were depleted. And what you see if you do that only during these a couple of days of culture, that later after birth you see a difference in growth between the groups of animals. But also other conditions that are relevant for culture medium, like pH, which is partly a result of the composition of the culture media. If you have a pH shock, and this is quite a big shock, but still, of only 15 minutes during embryo culture, this can result in a different birth weight and development later on. So yes, by doing these experiments, it's known that the pre-implantation culture is important. But we also have the data sets, the clinical evidence from humans, and I think this has been a landmark paper by John de Molin, who is an embryologist from the south of the Netherlands, from Maastricht. And what he did is a kind of quality control in his laboratory. He used 2 culture media during the IVF procedures. And later on, I mean, it was not a bigger topic then, but later on he investigated the children, and he found that there was a difference in birth weight between these 2 groups. And even a lot later, when these children were at the age of 9, this difference in birth weight was still present. This increased some attention and some increased research focus on the topic, but it was also discussed a lot because it was not a randomized setting, and people criticized it for that. And there was also a difference in weight between the mothers between both groups, which could explain the differences. So it was still unclear. So we didn't stop there. We proceeded together with John de Molin and in total 6 centers in the Netherlands by performing a randomized trial comparing 2 culture media, in this case G5 medium and the HTF culture medium. And we included a total of 800 couples in this trial. And what we saw comparing these 2 media between the 2 groups was a difference in the live birth rate. So one medium resulted in 6% more births than the other medium, but there was also a difference in birth weight between these groups. So this was for the first time by means of a large randomized trial in humans that we actually confirmed that a difference in birth weight between two media is possible. After publication, we saw some discussion in the scientific literature, even some controversy, maybe, but there were some supportive letters that stressed the importance of this finding and that we should take it seriously. But there was also some letters to the editor that criticized it and didn't take the results, criticized what we did and what we found. I personally don't think that is too much, or this is a big controversy, and that the letters that were sent in, well, about half of them were from authors that are involved in the culture media industry. So maybe it was not that convenient to have this worry, or it was not that convenient for them. But the other letters, a big part of the argument was that, oh, when I look at my comparisons and where I compared media, I don't see this difference in birth weight. Well, and actually that makes sense. You will not expect it all the time because there are differences in composition between the media, and some media are more similar and some media are more different. So sometimes you will expect a difference and sometimes you won't. But we don't know, because I don't know if you know, but the media companies don't disclose exactly what the concentrations are of the components in these culture media. So it's very difficult to make these comparisons. So what we did actually was we simply bought some time ago all culture media that were available to us then, and we brought them to our another department in our hospital and did an extensive analysis of the components. And I don't have the time to go into all details, but what we found is that none of the media had the same composition. Some were more similar and some were different, and that could explain, of course, the difference that you find in several studies, where some studies comparing media don't find a difference in, for example, birth weight or other outcomes, and others do. And in our trial, where we compared G5 and HDF, there is a big difference between the two media, and there is a lot of components present in one medium and not in the other. For example, the amino acids are present in one medium and not in the other, which could explain why we did find differences in our randomized trial. So that is, when you would like answers to the questions, does culture media have an effect on health outcomes, is the main issue. You don't know exactly what you compare. In similar media, you don't expect a difference, in others you do. And then again, another issue is what you see here to the right, is that if you compare, you have so many media. So if you compare medium A to B and C to D, you don't know the difference between A and D. So you need that many studies, and they are simply not available to us. But when you do a systematic review of the literature and see what is currently known in the scientific literature, and it is something Helene Sandstra from Maastricht did a while ago. She found 11 studies comparing media and looking, for example, at birth weight. And then 5 studies found a significant difference and 6 studies didn't find a difference. And what you do normally then is you say, okay, it's not known yet. Because if you do a systematic review and 10 studies say it's true and 1 study says it's not, then you say, well, the general consensus that we have something here. And in this case, you see conflicting results. And that can be explained by the composition of the media, but it also demonstrates that, a simple systematic review is not sufficient. You should really look at the details. And this particular research, when you look at long-term outcomes, and we also have seen it in the previous presentations, you'll find some difficulties. Because first of all, we see only a limited number of studies available in the literature. And I think that is quite surprising after 40 years of IVF, that the number of studies is simply limited. And if you see some studies, then the sample sizes are often limited, or they are of retrospective design, which comes with its own difficulties. And it is, for example, the methodology of these studies also make it very difficult to draw firm conclusions. And it was mentioned before, you see, for example, differences in and improvements in what we do in the lab or any clinic throughout time. I mean, the way we perform IVF now is completely different than we did like 10 years ago, or even like 20 years ago. And we know that quality and live birth rates improved. And with that, you could also expect differences to be found in these follow-up studies, especially the retrospective ones. And like mentioned before, very important, it's very difficult to estimate the effect of confounders, like, for example, the parental fertility, who has an effect on health outcomes. And then how are you going to discriminate between paternal effects or parental effects, and, for example, the clinic effect, like Professor Brison demonstrates to us, or you can pinpoint it to specific parts of the IVF procedure, like the culture medium. That's very difficult to discriminate. So that makes it particularly difficult if you talk about the effect of IVF on the health of children to come up with clear answers. And that can be wrong. We know how to do clinical studies. I mean, for example, if you have a discussion on IVF add-ons, and you would like to know whether an IVF add-on works, I mean, we can design a study, do IVF with and without the add-on, look at the live birth rate, see if it improves. You can come up with the answers fairly easy. But in this case, that is more difficult. So how should we proceed?
Sorry, Sebastiaan, I need you to wrap up quite quickly now. You're running over.
I will do that. So how should we proceed? Well, we still have to do those studies. How difficult they are, we should do them as follow-up of RCTs, but also using the cohort data. And being involved in some of these retrospective analysis on IVF outcomes, in many cases, for example, the kind of medium was not ever, even recorded in the patient files. So for the colleagues that are enjoying this stream, they can change something today to help us in doing these research. Make note of what medium was used, for example, with every treatment, with every cycle. And what you can also start doing, if you're not doing it already, is ask your patients informed consent to contact them later, because with new European legislation, it becomes increasingly difficult to even contact the patients in, like, let's say 5 or 10 years, if they didn't provide informed consent to you today. And of course, and it has been mentioned before, we should do the basic and translational and evaluation research to see what actually is going on. So to sum up, is there a culture media effect on children? Yes, I think that's clear. I mean, there is preclinical and clinical evidence that demonstrates that the culture media can have an effect on embryo development, and with that on the health of the children born and probably even later in life. But the questions that remain, of course, are, does this matter? I mean, we have 8 million children born after IVF. They in general look healthy. We see some differences or increased risk profiles. But for example, the difference in birth weight, does it matter? Or is it within biological variance? And can we approve as clinical embryologists? And should we look at other outcomes? And what about the effect sizes? And can we change the medium? How should we change it? These are all questions that still remain. And as an embryologist, I see that the effect is there. So I also think it's my responsibility to find out the answer to these questions, to improve on our IVF culture even more than we already do today. But I also discussed with you that the challenges, there are clear methodological challenges for these questions, but also the interest in follow-up studies is limited. I mean, in general in the world, IVF is practiced in private clinics, and there it is often not their interest or a possibility at all to do such studies. But we should still do them. Thank you so much.
We've got loads of questions. I'm going to, someone has answered in the Q&A, which is handy, because a lot of people were asking about what is low birth weight. So Tazeen Ashraf has answered that kindly for the panel, saying, for those asking, the WHO definitions are low birth weight is less than 2,500 grams, very low birth weight is less than 1,500 grams, and extremely low birth weight is less than 1,000 grams. So, so I hope that's now clear for everybody. Okay, so the first question that I'm going to take is from Ginny Clark, and she wants to know, is PGD more likely to cause problems in the child than IVF or not? And I think I'll go to Anja first of all with that one.
Thank you for that question, and it's extremely interesting. However, there have not been so many follow-up studies on obstetric and perinatal outcome after PGD. But what it seems from those studies that are there is that there are no major harm done to the children by doing PGT or PGD. So I think from the existing studies, well knowing that we still need some follow-up, there's no real long-term follow-up on the children, but on malformations, for example, we don't see any higher risk in the studies performed at the moment. I don't think if any other of the speakers will add something to.
Does anybody else want to come in on that? No, I can't see any hands up. So we'll move on to the next question, which is from an anonymous attendee. Do you think there is an association between male infertility, male factor infertility, and the association of poorer IVF, ICSI babies' health, and should it be a concern? So, so I don't know who wants to take that one first. I'm going to go to perhaps to Sebastiaan first this time, and then we'll see if anyone's got anything else to add.
Yeah, there seems to be an association. I'm not fully aware of that, but last week I had the pleasure of enjoying a presentation by Professor Pinborg, who came up with a slide, so maybe she can add to that, on a study where there was demonstrated an increased mortality among men with who were diagnosed with impaired fertility. So there seems to be a relationship, but I cannot specify to what extent this risk is increased.
So, Anja, would you like to come in on this one then, please?
Yeah, thank you. There are studies by the Eisenberg group in the US where they have showed that males with severe male infertility and esospermia has a higher risk of mortality and disease. But I think this question were more on the children. And we know that there is a slight increased risk of chromosomal abnormalities in the children born after males, not on the from the ICSI procedure itself, but probably from the severe male factor infertility of males with very low or very poor semen quality. So there is a slight association also to malformations we have seen, but it's still very much related to very, very severe male factor infertility.
And there's a follow-up question actually that I think you might as well deal with now, is that whether anyone's looked at whether there's an increase in male fertility in boys born after ICSI.
Yeah, yes, that has been looked at the Brussels group, and that was presented by Professor Belva in the ESRA Congress some years ago, and it's also a publication in Human Production, and it shows that in males with from fathers who have had very poor semen quality, there's also a lower semen quality in the boys. Although it's quite a small study, it's a study where they have followed, they invented the ICSI procedure, and it's that cohort they have followed. And in that cohort, they found a lower semen quality. And I think there have been some smaller studies showing similar results after that.
Thank you. Does anyone else want to come in on that male factor question? If not, I will move on. We have a question for Daniel from Jane Stewart, and she wants to know if you can comment on birth weight, the clinic site, and the position of the clinic in relation to UK areas of poor health. Is that an association that you've seen or that anyone's looked at?
Okay, thank you, Jane. That's a good question. We haven't looked at geographical location per se, but we have looked at socioeconomic deprivation index. So we did that in the Scottish study and also one of Catherine Castillo's studies. And so we've controlled for socioeconomic index in birth weight and child growth. And I don't think we certainly didn't see any strong association. And the associations we saw were independent of socioeconomic background. So we've done it from that extent. We haven't targeted particularly any areas with poorer health outcomes specifically. That's my memory of the studies, although Steve Roberts is the public health expert on our team. I'd have to check with him. That's my recollection of the design.
Does anyone else want to come in on this? No, I'm not seeing any hands up. So we'll move on to the next one, which is also for you, Daniel, from Roger Sterney. He wants to know, why are FET embryos born with birth weights closer to natural conception? Is this related to the environment, i.e. the uterus, into which they're transferred, recovering from stimulation?
So I've gone on a journey with this. When I first started looking at these data produced by other countries, I was convinced it was an issue with embryo freezing. And we've done some molecular biology studies showing that human embryos that are frozen thawed have a different gene expression profile to embryos which are not frozen thawed. But actually, when you look at the data, I think it's fairly clear that the association between freezing and birth weight is not to do with freezing, it's to do with the endometrial environment. There are several lines of evidence for that. One is that if you look at stimulation response by women undergoing IVF, there's an association with how heavily they respond or are stimulated and birth weight to some extent. And also the fact that the differences you see are consistent in frozen embryo transfers and consistently above the birth weights you see for naturally conceived children. So of course that cannot logically be explained by the freezing process. So I think at the moment I would come down on it being a function of the stimulated endometrial environment. Thanks for the question.
And do any of the others want to come in on that, Sebastiaan?
Yeah, I think this is one of the major questions that deserves our attention in the coming years, because there is a clear difference there. And it was always, I mean, I just want to point out a kind of shift in thinking that we always thought, okay, children after IVF have a too low birth weight, and children after cryotransfer, those are the normal ones. But I think there is increasing appreciation for the fact that these are often also too large for gestational age. So you see them shift in the whole spectrum and have a high birth weight, but we still don't know what we're doing there and whether we do good at all, and whether we should improve on that.
Okay.
There has actually, if I may comment, there has actually been some studies lately debating the different protocols for stimulating for frozen embryo transfer, where it has been found that if you do a substituted cycle with stimulation of the endometrium by estradiol and progesterone, creating no corpus luteum, you will have a higher risk of preterm birth, of large gestational age, and also for preeclampsia. So it indicates, and many of frozen embryo transfer cycles are actually performed in these artificially prepared endometriums without a corpus luteum. And the Valerie Baker group and the Fersen-Hunk group has made some interesting publication where they have shown that in early pregnancy without a corpus luteum, you have absolutely no hormone called relaxin, which is a very important hormone for relaxation of the smooth muscles and skeletal muscles. So the mothers in these pregnancies without no corpus luteum actually has a cardiovascular compromise and cannot adapt to the early pregnancy, which may be followed by preeclampsia and overgrowth of the placenta. So this is really an interesting debate, and I think we will see much more literature on this. And I think we should stop doing all these artificial cycles whenever it's possible to do it in another way.
I just add to that, I think the corpus luteum papers were really fascinating. I agree. And it's a really nice way to look at the issue. All I can say is in our studies, we didn't see that. So one of Catherine Castillo's papers, we looked at, I think, 6,000 live birth cycles, and we saw no association between the type of endometrial preparation in the FET cycle and birth weight. I mean, that could have been for a lot of reasons, of course, and we could go back and reanalyze the data. We didn't see a clear association. We did look specifically for it. So I don't know why that was.
No, it has been shown in more cohorts, both in the Scandinavian, both in the Danish and the Swedish study, and in also from other parts of the world. So there are at least some interest, but we need to dig much more deeper into that.
Yeah, I agree.
Okay, I'm going to move on to another question now, and I'm going to this one is going to be for Carrie. So this is from somebody who's chosen to be anonymous. Most of these studies are old enough not to be counting a blastocyst culture, which obviously we know we've moved to more and more over the years. And those extra days in culture must affect the epigenetics of the embryos, and possibly we'll have more negative outcomes in future studies. Do you think that's that questioner is right, that it is a cause for concern or not, that the extended culture that we use now?
Well, I'm just trying to wrap my brain now to see how, what percentage of blastocyst transfers we had in our study. We certainly had a reasonable number of them. I can't remember whether can you remember in your study, Anja, exactly how many blastocyst transfers? But I think there was a reasonable number, and because the studies are so large, well, have been quite large so far, there hasn't been any suggestion of that so far, but it is something to bear in mind. And again, it's important to continue these studies to see if changes in the IVF protocols are resulting in differences in the outcomes. But as far as I remember from our study, there was a reasonable proportion of blastocyst transfers within that. Do you remember in your study, Anja?
Yeah, in our study, it was very few because the children were in that study only followed up to 2008. So we will have almost no blastocyst transfer in that study. So I think we still need, I think there are some studies indicating, I think Sebastiaan showed that on blastocyst transfer and the higher risk of preterm birth. So there is slight, but it's also a new procedure. So I think we need some more follow-up studies. And I think there are some controversies in those papers published until now. It's not a huge difference between blastocyst and day 2 culture. At least they are not overgrowth, which we actually were a little bit afraid they would be.
So it doesn't always go as you predict then, perhaps.
Sarah, I'm just going to look up now just to confirm the numbers from our study, so we'll get back to you in a second.
Great. Thank you. Okay, so the next question from Alina Pelik. So she's thanking everybody. What is the association between male and female subfertility and the various outcomes? A lot of attention is usually drawn to endometriosis and PCOS. If you looked into it, have you found differences in outcomes depending on the nature or the cause of the subfertility of the patient? So I don't know who wants to go first on that, perhaps Anja.
Yeah, it's always in the cohort studies, the diagnoses are always not so valid and are missing in many cases. But what we can see is that male factor infertility is actually causing, in the ICSI population, we see a higher birth weight, probably because it's the healthy females. So if you have fibromyalgia or endometriosis, there's no doubt. And we know in particular on publications only in endometriosis patients, we know that they have higher obstetric risk. They have higher risk of bleeding in pregnancy, uterine rupture, and so on. So there's no doubt that the endometriosis population accounts for a reproductively very ill population, or proportionally more ill than the other parts. And then there's the anovulatory women, which also is a different population from the others. But the convincing studies are not there, that there are some very major differences between, for example, malformations in any of these female groups.
Sebastiaan or Daniel, did you want to come in on that one, or shall we? move on so we can get through perhaps one or two more questions. Anonymous wants to know, are there any differences between donor IVF and using your own eggs and sperm? And has this area been researched? I don't remember that coming up in any of your presentations. So perhaps Sebastiaan, are you aware of any research in relation to the outcomes for donor conceived children?
No, I'm not aware of the latest in this, but well, but in general, it's always good to keep in mind that although there could be small increased risks relative to one another, I mean, in this case, it's often not an option to choose one over the other. So the clinical practice and what you decide to do still remains the same, but maybe somebody else is more aware about the most recent data on that.
And certainly from a cancer point of view, we published a small study looking at cancer risk in children born after donor IVF, and there was no increased risk in our cohort, but it was quite a small cohort. So again, it's something to keep in mind and follow up. But the data that we had didn't show an increased risk.
Regarding the donor eggs, we know that there is certainly an increased risk of preeclampsia in these pregnancies. Such a high risk as 2.4-fold increased risk, and therefore many societies have actually recommended that you give acid to the women with the donor eggs.
That's interesting. Right, I'm very conscious of time now. So we have a question from Joanne Delange, and this is for Daniel, and this is again about birth weight, and she wants to know, is a small birth weight and catch-up growth and the long-term health implications the same for IVF babies and naturally conceived babies, and have the two been compared and studied in that way? So Daniel, if you want to take that one first, and then we'll let others chip in.
Sure, that's a very good question. In fact, exactly the right question, because all of the data we have on the long-term effects of birth weight and catch-up growth are based on normally conceived, naturally conceived populations, of course, and they are also associations. We don't know the mechanism. So that's exactly the right question. We know that this applies to non-ART populations, but we don't yet know if it does apply to ART. All we know is that the growth patterns of ART children are different. So there's a risk factor, but we don't know the implications yet. And of course, we won't know that for quite a few years.
Okay, so we're going to have to wrap up. Carrie, did you get the answer that you wanted about your blastocyst numbers?
Yes, sorry, I was slightly wrong about that. So we had about 5,000 children born after blastocyst transfer in a 106,000 cohort. So not a big percentage. Actually, the majority of the data was missing, so we were unclear for the majority of it. But actually, in that 5,000, we didn't find an increased risk. But as I said before, that's sort of quite a small cohort to be reassuring by. So another reason why follow-up studies and continued monitoring of this population is really important.